A wonderful Saturday with a lot of new information. I really hope you are ready. This is the way we are going to do with science. If you add up these numbers, then you are going to get 71%, namely the mammograms look like this of those cancers that still kill, despite screening, despite the oncologists are doing everything in their power. That's not good. We are extremely happy that we decrease mortality by 50%. But these women, despite screening and using modern therapy, still dying, and 71% of them have this mammogram. Let's do something about it. One of the main players look like this. We call it imaging biomarker, fragmented casting type calcification. Among the DABs, it's not the skipping stone-like, not the non-calcified architectural distortion, but this one is a bad actor. Dear colleagues, this was so important for us to answer the question, why do women still die from breast cancer? One of the main actors is this one. The other one, the topic of future lectures, is the BCMO and pleomorphic hand in hand. And our statisticians were kind enough to provide the following information. You might have experienced, I definitely experienced in my clinical practice, that women with casting type calcifications, very often young, there is a significant difference between the age distribution of women with fragmented casting type calcification compared to all cancers. We are dealing with 9,224 cancers. Very important take-home message, number one. Number two, I not only show Kaplan-Meier survival curves, but I translate it to your language, my language. Women whose mammogram only have casting type calcifications and neither the radiologist nor the pathologist can find associated invasive carcinoma. You cannot call them DCIS because we all know that there is a bunch of newly formed duct neoduct genesis. At this time point, they were caught before they could cause harm. The survival in the long term, 88%. If the same mammographic image is found to be associated with 1 to 14 millimeter stellate or circular lesions, for the time being we call it AABs. Later on, we are going to split the AAB to real AABs and de-differentiated DAB. Something magical happens when the not associated and the associated with even 1 to 14 millimeter invasive carcinoma shows up. Suddenly, 30% of them running a higher risk of dying from the disease. But the cancer originates from the TDLU in its in situ phase, as in our adenocarcinoma of the breast, expressed on the mammogram as crushed stone-like pleomorphic calcifications, without and with associated AAB. Fabulous long-term survival. We are talking about at least 39 years survival. This shows what we have always talked about. These cases, called DCIS, are terribly overtreated. These cases, called DCIS, terribly undertreated. And these account for the vast majority of the cancers. This is a surgical disease, but this one, neither surgery nor oncology can cure all of them. Yes, 70%, but no, for 30%. Very important figure for you to take home. Same thing, when the cancer originates from the TDLU, we are fortunate in the breast, we are fortunate in the prostate, in the salivary glands. Also, women or men are fortunate because 70 plus 75% of all cancers originate from here. About 5% originate from the stem cells of the mesenchyme, but around 20% originate from the major lactiferous ducts, micropapillary, solid cell proliferation, and so on. And as soon as they are associated with small or large, call it microinvasion, the survival curve is sinking. I'm trying to tell the medical community, why do women die from breast cancer? If you look at the immunohistochemical biomarkers, you cannot answer the question. Please learn imaging biomarkers. Not a rocket science. I can teach anybody in 15 minutes. This is the same thing expressed on a long-term survival curve, dear colleagues. So far, I was talking about AAB, stellate or circular lesions associated with casting-type calcifications. I teamed up with a brilliant pathologist, according to me, the most modern-thinking pathologist, and his name is Lee Tucker. We have been friends for 30 years. I invited him to our research team, and with a joint effort, we started to split this. It's his brilliant knowledge in histology that carved out something he calls de-differentiated DAB. And it doesn't form a stellate or circular lesion. No, it's diffuse. Microinvasion can be larger, but if these two are together, very high risk of fatality. And then the rest of the AABs can be a grade 1, 2 invasive carcinoma, AAB. What we plan to do is to find out whether I can help the oncologists, the surgeons, or right after the first surgery, who belongs to this and who are going to do well. So far, we were not able to distinguish. All of you might have had very extensive casting on a region the size of your palm, and 10 years later, she dies from a stroke or something like that. And sometimes you find baby castings and some invasive cancer, which a pathologist don't dare to say ductal or lobular. They say poorly differentiated invasive cancer, and she dies. I think our joint effort is getting very close to say who is going to belong here and who belongs here. Let's do it. She's 81, presented with a self-detected tumor mass in the upper portion of her right breast. Well, not a problem for a radiologist. However, I hope you immediately recognize that this is pretty much confined. Run all the way to the chest wall. I'm going to outline these teaching points for you. You heard my lectures about the neo-acinogenesis. I think many of these started like that. So these are casting, and there is a huge stellate lesion, which half a year ago I would have called AAB and DAB. Well, that's not the case. Here is a second teaching point. Would you mind looking at what's inside that so-called AAB? That is not at all AAB. It's zillions of DABs that build this stellate lesion. That's interesting. It starts here as a totally atrophic field. Let me show it to you on a video. This is what an 80-year-old woman's breast tissue should look like. Desert, totally atrophic fibrous tissue. Huge distance between the atrophic ducts, hardly any acinus or TDLU. That's how Mother Nature works. But then suddenly, there are a large number of ducts, duct-like structures full of fluid, caused by cancer, as you see, on the inside wall of the basement membrane. It's micropapillary, and also you see invasive micropapillary, dear colleagues. This is AAB. But it's somehow very strange that it spills out to the fat. Let's magnify. What is this? Cholesterol crystals. So there is not only fluid production by these cribriform and micropapillary tumor growth, but also there must be necrosis. So let's analyze this simple case. Keep in mind the mammogram. Yes, these are the cholesterol crystals. And this is fluid production. You see here the micropapillary. And then there is invasive micropapillary. If she is going to get distant metastasis, we are going to try to answer the question, was it the AAB that caused the trouble? Oh, it's a beautiful neoduct genesis kind of breaking out. But this one is AAB. That's the invasive micropapillary. You remember we already talked about how you recognize it as if there was a hole and the cancer cells were kind of cuddling inside that cavity. It's AAB. Yeah, partly yes. But there is a very extensive so-called DCIS, as the pathologists call it, but we call it neoacinogenesis or neoductionis, vascular invasion, and HER2 positivity and high Ki-67. It took 6 years and 5 months. The patient developed chest wall metastasis. What I learned from Lee, the histopathologic appearance of dedifferentiated DAB. The cancer cells are very close to each other. Among the cancer cells, there is no fibrosis. Try to memorize this picture, dear colleagues. This is dedifferentiated DAB. And this one is the invasive micropapillary AAB. And this is the dedifferentiated DAB. So here is my friend, and I'm asking him, write an article for the other pathologists in a credible way so they can distinguish AAB from DAB. Read what he says. These are predominantly solid cell growth pattern. The cancer cells are tightly packed. Small islets, larger islets, cohesive groupings without any or very little of the intervening collagen, which is very characteristic for AAB. Oh, this would be the AAB. Here is a cell, and there is that fibrosis, what he's talking about, separating one cell from another. He says that the AAB is genetically distinct neoplasm. It has the ability to reorder the extracellular matrix. Here is one cell, here is another cell, with altered collagen in a way not seen in DAB. This would be the AAB, acinar adenocarcinoma of the breast. And this would be the dedifferentiated DAB. This is what we call DAB when you see the solid or micropapillary cell proliferation. We see this ring, but this is a dedifferentiated, and memorize the difference between one and the other. Here is a talented radiologist in Belgrade, Serbia. I'm communicating with colleagues, with Lee Tucker, with Hiradine, with Natasha. This is what we call teamwork. She said something. I'd like to understand the dedifferentiated DAB in a way that the DAB is ready to make a neoduct. The cells drill into the surrounding tissue. If the DAB cells start drilling, but something goes wrong in the process, the cells are simply invading the surrounding tissue as dedifferentiated DAB. Since the cells have lost their ability to form a new tube. So I passed this over to Lee, who immediately jumped at the bandwagon. He says, You know, the process of neoductgenesis, that is, this is the main duct, and then the process of neoductgenesis is going like this, must involve genetic coding for differentiation as a duct, a cohesive cylindric structure. But the normal is different. It's a tube from the outset. Neoducts? No. When the cancer cells escape from the main duct full of cancer cells, then there is no tube. No, the neoducts are fundamentally different because they form a solid cylinder. The sausage is full. The cancer cells break through and produce this solid cylinder. Some of them is going to produce some lumen with the central necrosis and calcification. But the dedifferentiated DAB never got so far. I'm going to sum up that we are talking about two processes, one of them a neoductgenesis, that this one, the dedifferentiated DAB, never got so far as forming a cylinder. So whatever the genetic information is required for cylinder formation, it gets lost. Uses the same word Natasha was using. Hey, isn't that a mechanism for dedifferentiation? Losing things. So then László sums up with the smart colleagues and my own ideas and say, I really believe that there are two processes going on. Neoductgenesis. But that's not enough. Here comes the new. The dedifferentiated DAB. As soon as this shows up and got married with this one, fatality rate is high. We have to work so much more to prove all these. The summary is that there are two processes going hand in hand, neoductgenesis and the other one, when the cancer cells lose their ability to produce a tube-like structure. I didn't see a single case where the pathologist told invasive ductal or lobular. They just say poorly differentiated invasive carcinoma. So they feel that something is wrong, but they don't know where it originates from. Certainly not the TDLU. The pathologist cannot see the connection with the acini. We call it dedifferentiated DAB. Do you see the pattern? Whatever staining we are using in this case, please remember this kind of, I don't know, if you find out a good term, map-like pattern. Progesterone staining, same thing. Gata3 to prove its breast cancer origin. HER2 staining, exactly the same pattern. Here we go. Beautiful. Arms and legs. No nests of cancer cells like in AAB, no. 7 years and 5 months after diagnosis and treatment and 1 year after the chest wall metastasis, the patient died from disseminated neoductgenesis. I'm going to show you one case after the other